Good evening. Welcome back to our very popular monthly class, Nobi Pulmonology Master Class. And this time, our topic is lung cancer and precision medicine. A little about Nobi, particularly our both speakers are also to be introduced to Nobi. National Allergy Asthma Bronchitis Institute started its journey in 2008, 1st July, the birth date of legendary Professor Dr. Pidhan Chandra Rai. That's also our birthday. Primarily, it's a research institute. Equally strong are two other segments, the clinic part and the teaching part. We had very good modules on ILD, on tuberculosis, on obstructive airway disease, which were taught all over India and abroad. Post-pandemic, we have changed to online this monthly class, Nobi Pulmonology Master Class. It's very popular all over India and we get audiences from abroad as well. Today our topic is lung cancer and precision medicine. Actually, we do not choose the topic. The topics are chosen by our audience. We get inputs all over the time, month, previous month, even prior to that. And they wanted that actually the precision medicine is my addition. I am a little biased to this. Their topic was lung cancer, the current update. I wrote precision medicine because being a pulmonologist and Pawan don't mind it, our precision medicine still stands at eosinophil percentage, 3% or 2%. That is our precision medicine in obstructive airway disease. Compared to what oncology has done, the maximum exponent of precision medicine at present, there are few other segments as like oncology. They have revolutionized. My hardcore oncologist colleagues do not agree with me. They say it is just the beginning. I also feel so, yes, it is just the beginning. But every student, pre and postgraduate, must be conversed with the recent updates in precision medicine in oncology. I am the medical director, Nobi, Kolkata, and there are some achievements not that worth mentioning in my CV. But today we have the best two of the new generation, Dr. Pawan Singh and Dr. Sudeep Das. Pawan is Associate Professor, PGIMS Rohtak, is MD and DM in Pulmonary and Critical Care. Pawan has some emotional dedication to the subject of lung cancer and oncology. And recently he has conducted a very successful conference in Rohtak with faculty all over India and abroad. And Sudeep is, by the way, hardcore medical oncologist. He is from Tata Memorial Hospital, Mumbai, MD from AIMS, DNB in medical oncology, and European certified medical oncologist. Practically, we have expected that today it will be a bit extended class. We will accommodate in the interaction session because lung cancer and precision medicine, our two new colleagues, they are bubbling with information. It is very difficult to keep them tight within the schedule. I remember we had a paper in 1981 or 82, presentation of lung cancer, mostly clinical. That time I don't remember even, so probably it will be 1980 because we didn't have much CT then. I had X-rays. So most of the time, presentations were at stage 4 or sometimes stage 3. Very fascinating stories. A senior executive wrote a letter to his both elderly wife from Delhi to Kolkata. So unexpected and so unusual were the languages that the lady contacted one medical person, and it turned out that elderly person, heavy smoker, had brain metastasis from bronchogenic carcinoma. And those time I remember we used to do rigid bronchoscopy. Very painful procedure. Even that time I was aghast with this. I hoped, and we soon got it also, that one day we will get flexible fiber optic bronchoscopy. Much has changed over the years. Probably our faculty will tell us whether they get the cases now in earlier stage. So when a patient we suspect to be lung cancer, these are the goals that we try to approach. First, the clinical extent and stage of disease, then optimal target site and modality for tissue biopsy, specific histologic subtype determination, and now in the era of molecular biology, genotype of the cancer. Then come back to clinics again, presence of comorbidities, secondary complications, and again, it was always valuable, now more, patient values and preferences. We'll cover all these within the span of, say, next 85 to 90 minutes. To stress again, Nobi Pulmonology Masterclass is not just another webinar. It's a class. We follow the standard classroom method, starting from the basics, clearing the controversies, and then the updates. So now I will invite Dr. Pawan Singh for his presentation. Pawan, please. Recording to বন্ধ করতে হবে। Recording. Your screen sharing বন্ধ করতে। হ্যাঁ? আচ্ছা।
Good evening, everyone. I would like to thank Dr. Alok, Dr. Rajadhar, Pranali, and Arvind for their extreme support and the opportunity to work along with them for this Nabi Pulmonology Masterclass, which is a very noble initiative, and I wish it was there when I was a student. The topic that has been assigned to me is very close to my heart. I am a very odd pulmonologist who is involved with lung cancer, but from right from the diagnosis to the end of treatment, their side effects, and finally the palliative care and diagnosis. But today I will be going to focus only on clinical approach, classification, and diagnosis. The later part will be taken by my senior colleague, which will include the management. Now, from what I am aware, majority of my audience is postgraduate students who are either going for an exam or have a very basic understanding of the lung part and the lung cancer part. So I will try to keep it very basic so that you know what you are doing and what is bare minimum for you to reach up to a right diagnosis and how about to move from their point forth. So hi, I am Dr. Pawan. I have no disclosures or conflict of interest to declare. Now, why do we need to study lung cancer, particularly at your stage? So why do you need to study in next 3 or 4 years? So you will encounter these cases most likely daily or at least 2 to 3 times per week. It includes a very major part of pulmonology practice. It may be screening for lung cancer. It may be the diagnosis of lung cancer. It may be management of COPD in lung cancer patients. or management of adverse events of lung cancer therapies. So every part of lung cancer care is deeply integrated with pulmonology. Pulmonologist is involved at all stages. It may be diagnosis, tissue sampling, management, palliation, side effect management, almost everywhere. But most importantly, we want to pass the exam. And for exams, lung cancer is like the most important part of the practicals. There are few rules when you deal with lung cancer. It might be possible that you are not very interested in lung cancer. You might be reluctant to treat lung cancer patients, but there are some basic rules which you, if you know, you can deal with these cases and give the maximum benefit to them. So these rules are made by me, and I hope you will have some concordance with these rules. First of all, never ever treat any case without a diagnosis or a provisional diagnosis. For lung cancer cases specifically, it is illegal. No cancer patient can be treated without a tissue diagnosis, no matter what your suspicion or what the urgency with the patient might be. Always get a tissue. For lung cancer, for any cancer, tissue is gold. And tissue procurement in lung cancer is very difficult. Specifically lung organ is very difficult. So tissue is gold. You cannot miss the chance to have a sufficient amount of tissue before the treatment is initiated. Keep your nihilism to yourself. I am very certain and very aware that majority of my senior colleagues are very nihilistic when it comes to lung cancer, but the world has moved on. Number of therapies that are available is far beyond anybody's reach or their imagination. So keep your nihilism to yourself, because your patient might be better off without it. Don't remember or memorize the staging, because you are not supposed to do that. You are just supposed to make an important note of make a note of some important parts, but you are not supposed to memorize or cram up the staging. And if somebody asks you what is a stage, you just have to know some basic parts, but don't ever expect anybody to ask you complete histological stage for a lung cancer patient. Not all symptoms of a patient are due to cancer. COPD is very common in these patients. These patients are at very high risk of coronary artery disease, and including other types of illnesses. So do not ignore those symptoms and try to understand the holistic patient as a whole, and be ready to attribute some symptoms to other illnesses except for cancer. Smoking is harmful even before the illness and even after the illness. The patients of lung cancer who continue to smoke after diagnosis have a poor survival irrespective of the performance status. Finally, diagnosis does not end at histology. You are not living in a stone age right now. All histological cases have to be differentiated based on molecular evidence and molecular profiling. So do not think that your diagnosis or your treatment will end at the time of histology. You have to specify which kind of molecular mutations or genetic alterations are present in your patient so that a treatment can be initiated. Now let's start with epidemiology. Just to establish a common question, and finally to give you an answer that you can quote to anybody or any of your examiners. They might not be updated about it, but lung cancer is the most common cancer in males and fifth most common cancer in females. When you combine these two things, it is the second most common cancer after breast. What I'm talking about is age adjusted rates. You cannot compare the lung cancer, the prevalence of lung cancer in people who are of age in their teens or their 20s or their 30s. You have to adjust the denominator of incidence and prevalence as per the age of that particular population. So for age adjusted rates, that can be prevalence or that can be incidence, lung cancer is the most common cancer in males and fifth most common in females. The risk factors of lung cancer which are proven include smoking, air pollution, and family history. These are the three most important factors, and these three factors are now being evaluated to identify the high risk cases so that screening can be done. So these are the three factors which are included for lung cancer screening or are being tested for the same. Rarer but proven risk factors include radon, which is not commonly seen in India, asbestos. The data of asbestos is not frequently available, but it is a very commonly used item in India. So contribution to of asbestos to lung cancer is really not known, but it might be significant. There might be a significant proportion to the uh, entire number of cases. Finally, there is radiation exposure and tuberculosis. So, having established the epidemiology and the demography of lung cancer patients, my flow of slides will include symptoms, signs, investigations, tissue sampling, classification, staging, and finally, what are the advances. I'm not going to touch too much on the advances because that will be beyond the scope of this discussion. So, let's start with symptoms of the clinical approach. Most common symptom of lung cancer in our area of practice is the chest pain. The chest pain is usually a localized chest pain and has an onset of weeks to months. It is not days, it is not minutes, it is not years. So you have to understand that onset of chest pain is usually acute to subacute. It is not chronic and it is not sudden. Hemoptysis is a very common symptom of lung cancer, even though TB and post-TB lung diseases, which include chronic pulmonary aspergillosis, are also very common. But hemoptysis remains a very important symptom of endobronchial lesions, of which one of them is lung cancer. New onset dyspnea because of pulmonary embolism or pleural effusion. Lung cancer, as such, the mass itself does not cause dyspnea. So dyspnea can be because of pulmonary embolism or effusion or a coexistent ILD or COPD. So new onset dyspnea, which is again acute to subacute. Then there are constitutional symptoms which are nearly present in all patients, that is anorexia or weight loss. Weight loss that means more than 10% in past 6 months. Most of your patients will not be aware of their weight loss. So you have to ask them specific symptoms. Are their clothes loose now? Or have their sizes decreased? Or has somebody told you that you have become lean and thin? So these are some symptoms which can point towards weight loss, but exact quantification is usually not available. Then there is SVC syndrome. Very rarely a patient will complain that he has facial swelling or visible neck veins. So you have to present a history in such a manner that patient was told or patient was noticed to have dilated veins or bluish discoloration of face or facial swelling by somebody else for which patient has consulted us. So don't mention SVC syndrome directly. It is usually somebody else who is noticing changes on the face of the patient. Then there are symptoms of metastasis which are more common in non-smokers or in females. So these are bony pains or fractures, pathological fractures. Then there are brain metastasis, which usually is present in the form of headache, nausea, vomiting, amnesia. Amnesia is a very common symptom. Forgetfulness is a very common symptom of METs. Then there are seizures or convulsions and focal neurological deficit, that one hand is not working properly or one lower limb is not working properly. So CNS metastasis is very common in lung cancer. And finally, there are other symptoms like pain abdomen, which is usually because of liver metastasis. Now, there are some specific signs like clubbing. Clubbing, you have to understand the change is in the Loewe-Bond angle, not the angle between the nail. It is angle between the nail bed and the nail. Then there is SVC syndrome. SVC syndrome, as I previously mentioned, is seen in the form of veins which are dilated, neck veins which are dilated, prominent veins in upper part of thorax, and then there is facial swelling. A classical diurnal variation is also present in those symptoms. That patient has more symptoms in the early part of the day when he is getting out of his bed because he has been horizontal for a longer period of time. Then there is Horner syndrome. It is usually present in the form of signs because nobody else will notice such kind of symptoms. Don't try to fit your Horner syndrome history into your history part of your examination or the viva, because nobody tells somebody that his eyes is looking small or that. So this is usually a part of examination and not the history. Then there are other respiratory symptoms like feature that is suggestive of volume loss. So if there is an endobronchial lesion and there is a volume loss because of the collapse, then there will be shoulder droop. Chest wall will be flat. Chest wall flattening is noticed when the patient is lying supine. Don't try to mention the flattening of chest wall when the patient is either standing or sitting in front of you. So you ask the patient to lie supine, go at the foot end of the patient and look with your eyes up to the level of the toes of the patient. That's the time when you will notice some kind of chest wall flattening. Rib crowding is noticed with the hands, not with the eyes. So it is not part of inspection, but it is a part of palpation. Then there's pleural effusion. Pleural effusion will have signs like stony dull percussion and features suggestive of volume gain. Features of mass, like a mass which is touching the main airways, will cause, and reaching up to the chest wall will cause bronchial breathing sounds and bronchophony. Finally, there is one specific sign, that is dyspine sign. It is very common for lesions which are subcarinal, but exactly what this sign is, this is a homework for you guys. Now, starting with paraneoplastic syndromes in lung cancer. This list has to be remembered by majority of you guys, but truly speaking, I don't usually see such kind of patients. I frequently have seen patients who are suffering from gynecomastia, some cases with SIADH, that is syndrome of inappropriate antidiuretic hormone production. There have been some cases with humoral hypercalcemia of malignancy as well. So any patient who presents to you in altered sensorium and is suffering from lung cancer can be suffering from brain metastasis or a metabolic encephalopathy because of hyponatremia, which is in turn because of SIADH. Now, what are the investigations that you will ask from the patient? So whenever your examination talks about some investigation, then there are two things. One are specific investigations to prove or disprove your diagnosis, or to support your diagnosis, or to rule out some of the other differentials. And then there are some basic investigations. So you don't have to mention the basic investigations, which include hematological investigations, viral markers, and biochemistry. But specifically for lung cancer, a chest radiography is a must in order to suspect initially. But let me be very clear, the chest radiography cannot prove, neither it can prove or nor it can rule out lung cancer as a diagnosis. So mandatory investigation will include contrast enhanced computed tomography of thorax with upper abdomen. Now, whenever somebody tells you to get a CCT chest, it is understood or taken for that upper abdomen will be included in that. First thing. Second, any CT of thorax will be having three parts. One is the mediastinal window, then there is the lung window, and finally then there is the bone window. Usually the printouts of bone window is not available, the films are not provided, but it is commonly reported. So there are three parts of any CCT or CT thorax. Then there are preferred or optional investigations, like if the patient is affordable or if the patient is at high risk of metastasis. What I would commonly suggest or do is get an MRI brain and FDG PET CT to exactly know what kind of metastasis or what is the burden of the disease that patient is suffering from. So these are preferred or optional optional investigation that you might get done if your patient is either affordable or at high risk. Now starts the most important role of tissues of a pulmonologist, and that is the tissue sampling. So it depends upon the tumor location, where the tumor is located. That's how you will decide which weapon from your armamentarium that you will use. Second, the presence or absence of lymph nodes or pleural effusion. And the available commonly available techniques are flexible bronchoscopy, endobronchial ultrasound, mediastinal thoracoscopy, image guided biopsy or FNSC, and finally the surgical biopsy. So you have to understand that you have to use the least invasive form of tissue sampling method so that the patient is most comfortable. So if I am able to see a mass anywhere or palpate a mass anywhere from the body, and if I can take an FNSA and biopsy from that particular area, then I will prefer to use that. So supraclavicular lymph node is one of the most common sites from which I take a biopsy from, because it is usually present in these patients. In case it is available, then I do not want to take an FNSC from that lymph node. The lymph node should be biopsied or should be taken out in entities so that you have a sufficient amount of tissue for future immunohistochemistry or genetic alteration analysis. So this is the golden time when you can convince your patient to get a biopsy done or a or an FNSC plus cell block done, so that you have tissue and you are not being asked to repeat a biopsy on that particular patient. It is very easy to collect maximum amount of sample in your first sitting. It is very difficult to convince your patient to get a second sitting if you failed to make a diagnosis in the first part. So choose your decision to do one of these investigations very wisely, because you don't want to be over aggressive and you don't want to be under aggressive that you have to repeat your investigation, because repeating an investigation will cause financial burden on the patient, will cause him mental trauma for delay in diagnosis, and finally that the person who has to treat the patient will be facing a poorer performance status case because of your particular delay in obtaining a sufficient amount of tissue. So image guided biopsies, apart from the direct FNSC, that is supraclavicular lymph node, peripheral lesions are sampled either using USG guided or CT guided. So this is a USG guided transthoracic biopsy. You can see the air bronchograms beneath that. So masses which are abutting the chest wall are easily picked with an ultrasound, and we usually do ultrasound by ourselves so that patient does not have to go to other places. Finally, CT guided FNSC, which we do not usually do, are also done for lesions which are present in peripheral 1/3. You can divide your hemithorax into medial 1/3, peripheral 1/3, and the middle 1/3. So medial 1/3 is your area, our peripheral 1/3 is the radiologist area, and middle 1/3 is the no man's land. So all lesions which are present in peripheral 1/3 have to be sampled either by USG guided or CT guided FNSCs. So these lesions might have a risk of developing pneumothorax, but that's fine. It is not such a big deal that if pneumothorax will happen, the treatment will get delayed. By the time your tissue sample histology report comes, the pneumothorax is settled on its own or by using a pigtail. Then there is the use of flexible bronchoscopy and rigid bronchoscopy. From what I understand is we will have some sessions on bronchoscopy or interventional pulmonology, so I don't need to go into much of those details. One thing that I would like to emphasize is that whenever a mass has some cavitary content inside it, and it has an endobronchial extension as well, it is wiser to take biopsy from the bronchus in the form of endobronchial biopsy, because the probability of getting a right diagnosis or right tissue from that lesion is much higher if you are taking it from the periphery. And when we talk about endobronchial lesions, these are actually the peripheral lesions, peripheral part of that particular mass. Then finally comes the endobronchial ultrasound that can be curvilinear or it can be the radial. For curvilinear ultrasounds, it is a real-time FNSC that is done. Nowadays, people are also trying to get cryobiopsies from these needles. Cryobiopsy is usually helpful or mandatorily helpful in lesions where lymphoma is suspected. But for all other lesions, FNSC is nearly as good as getting a cryobiopsy done. So you always try to get the core tissue or sufficient amount of aspirate which can be used in cell block. Currently we are using liquid cytology techniques, so probability of getting diagnosis is very high even in fine needle aspiration specimens. For radial EBUS, you can only localize where the mass is actually located, and from that particular segment you can take endobronchial brush, TBNA, or cryobiopsy or endobronchial biopsy, which are usually blind TBLBs. So this is for peripheral lesions or the lesions which are present in middle 1/3 of the hemithorax, and this is for the lesions which are present in medial 1/3 of the hemithorax. So this is a very good exercise that I wanted to create. I wish I was live during this period and you guys had time to answer. So I will show you multiple CT scans and I want you to guess the right mode of sampling on those patients. And after every CT image, I will wait for 1 to 2 seconds so that you guys have time to think of an answer in your brains. So yes, you are right, either USG or CT guided. Again, USG or CT guided, quite peripheral lesion. This is quite medial lesion. So either you can do an EBUS in this lesion. What I would do, usually prefer, is get an EUS done. That is, use an EBUS scope take it inside the esophagus and biopsy is from that area, because patient is extremely comfortable when we are using an EUS instead of an EBUS. No coughing, patient is comfortable, less amount of sedation is required, and tissue that is collected is also much higher because we are able to take higher number of passes. So in this, I will use an endobronchial or endoesophageal ultrasound. Again, this is a lesion if somebody is not able to see. So you don't need an imaging for this. You can palpate the lesion from your the skin of the patient and then take the sample from there itself. In this, now this is a difficult area. You will do a check bronchoscopy in this particular patient. Either you can find the lesion. If you can find the lesion, radial EBUS is the first thing that I will try to use, because it is nearly end-on lesion from this side, or do a cryobiopsy using the radial EBUS guidance. If that is negative, then I will use a CT guided biopsy and let the pneumothorax develop. This is the lesion. There is no other probability to make a diagnosis except for using an EBUS. This can be done, depends you are a radiologist friend or a pulmonologist friend. This can be done, this should be done, I think, at the ultrasound guided or CT guided. Again, ultrasound or CT guided, you can find a lesion here as well using a routine check bronchoscopy. Classical end-on appearance, it can be done from both CT guided, or I would prefer bronchoscopy in this patient, because this can be a component of collapse as well. USG or CT guided. So this is, I'm sure majority of you guys must be thinking about using an EBUS or EUS in this patient. So this is one lesion which I would request all of you to just ignore and do not sample ever. This structure is fat. Look at the Hounsfield unit. This is air and this is soft tissue. It is slightly less dense than the soft tissue, and its HU is slightly more than lipid. So this is actually the fluid content, and this is a cyst. It is a bronchogenic or a neurogenic or an enterogenic cyst. If you sample, if you put a needle inside this, it is going to get infected. And this is not that it is there is high chance of it getting infected. It is like 100% sure shot will get infected, and it will lead to mediastinitis. So you should leave this lesion alone and ask the surgeon to just operate it and remove it completely. So no sampling for this lesion. Classical endobronchial appearance, bronchoscopy. Yes. So now coming on to the classification of lung tumors. In 2021, WHO gave an extensive classification of all lung thoracic tumors. That can be precursors or the cancerous lesions. It has been revised recently, but there are no significant changes in this. After WHO, International Association for Study of Lung Cancer is also giving classifications for lung tumors, but they are basically the same in the sense that you cannot memorize the list of these tumors. So what I'm going to tell you is a simplified classification of malignant lung tumors, which is used by the oncologist, which is used by the pathologist, and you are nobody to doubt either of them. So lung cancer can be either small cell or non-small cell, quite basic. So non-small cell can be squamous cell or non-squamous cell. So non-squamous cell is either adenocarcinoma, large cell, or not otherwise specific. So quite easy, nothing, no rocket science in this. I'm not going to bore you with the details. So small cell, non-small cell, squamous cell, non-squamous cell, adeno, large cell, and not otherwise specific. This is the most commonly used, and this is what is clinically relevant for deciding on the future testing of these samples. Now coming on to the staging. The TNM staging, the 8th version, is given by IASLC, International Association for Study of Lung Cancer. It is coming out with the 9th version, so all of the graduates, postgraduates who are in first or second year can wait for some time. By the end of next year, most probably we will have the 9th TNM staging, but it is not going to be much different from the 8th TNM. Small cell specifically is also classified according to the Veteran Affairs staging. It is mainly used by the radiotherapy people. There are some other versions as well, like early stage, localized, and advanced stage, which is used by the surgeons. So, but that is not very, very evidence based, but it is clinically relevant. So starting with basic principles that we have TNM, tumor characteristics, nodal invasion, and finally the metastasis. And the modality used for staging can be physical examination, imaging, bronchoscopy, or surgical. So for physical examination, I need to focus you have a focus your attention upon the use of palpation of for the neck lymph nodes. So the presence of supraclavicular lymph node, which is very characteristic of a malignant lesion, like it is hard, it is fixed, it is matted, it is immobile, it is more than 1.5 to 1 centimeter in size. All those characteristics indicate that it is a malignant lesion. Whenever somebody asks you whether the lymphadenopathy is significant or not, they want to ask you whether the physical examination characteristics of a lymph node can predict its malignant nature or not. People will say that if it is hard, it is matted, it is fixed, skin is fixed, there are sinuses that are developed, or it is adherent to the underlying structures, then it is significant lymphadenopathy. But let me be very clear: all studies which have demonstrated this aspect being significant indicated towards malignant versus benign etiology of lymphadenopathy, nothing else. So there is no one single cutoff for size, even though senior peoples do mention a cutoff of 1.5 centimeter for the supraclavicular and 1 centimeter for other lymph nodes and 2 centimeter size for inguinal lymphadenopathy. But that's not very scientific because I was not able to gather any evidence in support or against that particular theory. So physical examination is an important part of staging. Then we have imaging that can be CT, MRI, or PET scan. Then there is bronchoscopy or an endobronchial ultrasound, and finally surgical. A number of times you will face some patients who have undergone neurological assessment, who have a mass resected from their brain, and that turned out to be adenocarcinoma. I myself have a couple of patients right now who have been already operated for their CNS lesions, where the surgeon did not have a closer look at the X-ray of that patient. So surgical specimen is used not only by mistake but by actual conduct as well, because if the patient has only one lesion out of his thoracic cavity, you will like to prove that it is metastasis, because patient might be resectable if that particular lesion was not actually malignant. So starting with T descriptors. Now we have 7 descriptors. We have 7 T divisions: T1A, T1B, T1C, T2A, T2B, T3, T4. So 7. Now you divide all these numbers according to their sizes. T1A is less than 1 centimeter, T1B is less than 2 centimeter, T1C is less than 3 centimeter, T2A is less than 4 centimeter, T2B is less than 5 centimeter. 5 to 7 is T3 and more than 7 is T4. This is how I remember it, because among all these lesions, only difference is of size, nothing else. Now comes that size 2A. I've already T2B. If you don't know the size of the mass, let's say you got a CT done and the mass was mixed with the collapse, and you are not able to differentiate which part is the mass, which part is the lesion, or which part is the collapsed lung. In that case, you have to be conservative and you have to label it as T2A. Okay. So T2A is less than 4 centimeter, or the mass is not known what is the size, and T2B's mass is more than 4 centimeter. Again, involvement of main bronchi is T2 and not T3. In the last classification, it was T3, but currently any main bronchi involvement without cranial involvement is T2B. Now comes the T3. Now this is a very important part. First of all lesions more than 5 to 7 centimeters in size is T3. No doubt, very easy to understand. All Pancoast tumors. Pancoast tumor will be an important part of your examinations. All Pancoast tumors are T3, except those who are involving major vessels and vertebral body. Okay, so vertebral involvement and major vessel involvement, these should not be there. Other than that, all tumors are of Pancoast tumor are actually T3. Invasion of chest wall, which includes pleura, parietal pleura, is T3. So visceral pleura is T2, whereas parietal pleura, which is part of chest wall, is T3. So if the mass is invading into the chest wall, reaching up to the ribs, even in that case, the size of the lesion is less than 7 centimeters, then the lesion is T3, not T4. Finally, separate nodule in the same lobe is T3. Okay. So all Pancoast tumors are T3 except those involving the vertebral bodies or the major vessels or the major nerves. And involvement of chest wall is T3. Now T4. Let me get back to you. Yeah. Involvement of phrenic nerve and parietal pericardium, because you can remove the parietal pericardium very easily, and phrenic nerve is located outside pericardium. That's why T3. These tumors are labeled as T3. But involvement of recurrent laryngeal nerve is T4, because it is so close to the aorta. It is highly unlikely that if recurrent laryngeal nerve is involved, then the tumor has already invaded the major part of the mediastinum, that is aorta and other great vessels. So size more than 7 centimeters, easy to remember. Involvement of carina, great vessels, diaphragm, stomach, esophagus, vertebra, brachial plexus, all important structures are involved. Then it is T4. Only thing that you have to remember is phrenic nerve is not T4. And nodules in the same side but in a different lobe are T4. Now coming on to the end descriptors, very easy to remember. N1 are ipsilateral hilar lymph nodes. That means 11 and 12 and beyond that. N2 is involvement of mediastinal lymph nodes. Mediastinum includes 2, 4, 5, 2, 4, 2 upper paratracheal, 4 lower paratracheal, 5 subcarinal, 6 aortic, 5 is AP window, 6 is paraortic, 7 is subcarinal. So all these lymph nodes, even 10. So 10, 7, 6, 5, 4, and 2 are mediastinal lymph nodes. So involvement of mediastinal lymph nodes is N2 if on the same side. That means the lesion is on the right side and you are having an involvement of 4R or 2R, it is N2. If you have an involvement of subcarinal, that is 7, it is N2. But if it has involvement of 4L, then it is N3. So contralateral involvement of either mediastinal or hilar lymph nodes becomes N3. So any lesion, any lymph node which is above the level of clavicles, that is station 1, or is present in the opposite side of hilum, opposite side of the tumor, or opposite side of the mediastinum, that means it becomes N3. So all supraclavicle lymph nodes, opposite mediastinum, opposite hilar are N3 lymph nodes. Now very interesting fact. I am pretty sure none of you have noticed this. When you memorize these stations, 2, 3, 4, 6 and all those things, the medial part of the lesion is the left side of trachea. So I think I have a photograph. I don't have a photograph. Let's say, let me show you here. Yeah. So this is the left wall of trachea. So this is a medial border for all stations. Anything on this side is right side. Anything on this side, it is left side. So for all stations below 1, the left wall of trachea acts as the medial border to differentiate between left side and right side. But for all lesions above the clavicle or the station 1, the middle line of the trachea is the one that differentiates between the left side and the right side. Okay. Even though that hardly matters, because anything above clavicles is the N3 station lymphadenopathy, but still for MCQ purposes and everything. So this is what I was telling you. 1R and 1L are based on the midline of the trachea, whereas 2L and 2R are based on the left side, left wall of the trachea. So 2R and 2L are the upper paratracheal, 4R and 4 are the lower paratracheal, 7 is the subcarinal, 10 and 12 are the hilar lymph nodes. Station 5 is the AP window and station 6 is the para-aortic lymph node. Now coming on to the metastasis or the M descriptor, that is divided into three parts: M1A, M1B and M1C. All intrathoracic metastasis, which means nodules in the contralateral lung, malignant pleural effusion, malignant pericardial effusion, malignant pleural nodules or malignant pericardial nodules, everything is classified as M1A. It means that it is stage 4. There is no doubt of that. But still it is classified as M1A. Okay, stage 4, even though it is intrathoracic. Now, some of you might question whether a passively accumulated pleural effusion has to be tapped for proving it to be malignant, because majority of times if you have a sample and you know that patient is suffering from lung cancer and he has effusion as well, automatically it becomes stage 4 because of M1A. But sometimes you need to prove this as well, because let's say if you get a PET scan for that patient and the lesion is, let's say, 3 or 4 centimeter or 5 centimeter in size, there's no significant lymphadenopathy. The patient is otherwise resectable but has a mild to moderate effusion. In those cases, I would like to prove it that effusion is malignant or not, or benign or because of some other etiology. Because if the effusion is not malignant, patient will have to undergo surgery and patient is in a resectable stage. M1B is presence of one single metastasis in a single organ system. So one mass present extrathoracically in one organ system. If one organ system has more than one nodules or metastatic areas, then it is 1C. So if the liver has only one metastasis, then it is 1B. And if it has multiple or more than one organs are involved, then it is 1C. So 1A is included in T4A and 1A, M1A and M1B are included in 4A stage and M1C is included in 4B staging. Yes. So you don't need to remember these things, because I usually carry a chart even on my phone or on my OPD purposes. Anything that can be encompassed into a single port of radiotherapy is limited stage, and if it is not so, it is extensive stage. So let's say this is the mass, on the same side there are lymph nodes present, and you can burn everything with single port. That means that it is limited stage. If the patient has lesions on the opposite side, or let's say patient has an effusion present or the malignant deposits anywhere else, then it becomes extensive stage. So effusion makes it extensive stage. Other than that, all metastasis makes them extensive stage. So there are several advances which we need to discuss and should be aware about. One of them is lung cancer screening. We should know the protocol of lung cancer screening. We should know the type of nodules that you might face in lung cancer screening and what to do about them. And finally, the eligible patients. Whom would you like to screen? Even though it is a very controversial area, and I think India is not ready, but I strongly feel that there is certain populations in India who can afford, who can get benefited, and who are eligible for lung cancer screening. So you should be aware. If somebody, some of your patients ask you, should I get an LDCT done just for screening purposes? Then liquid biopsy is coming in a revolutionary form. So I'll give you a slight brief about what liquid biopsy is. You take blood of patient. Let's say you have taken 10 ml of the blood. You allow it to sediment either with centrifugation or passively. So all red blood cells will deposit. Then there will be platelets and WBCs which are getting deposited. The supernatant that is left is plasma. That plasma will contain practically no cells. There will be no cells that are present in that plasma, but it will contain some amount of DNA or RNA. So genetic material is always present. You take that plasma and you analyze this plasma, the cell-free DNA of this plasma, either with NGS or with PCR, and you try to find out the mutations. So yes, if the tumor has EGFR or ALK or any other kind of genetic alteration that can be picked up using a next generation sequencing from liquid biopsy, but you cannot tell whether a patient is suffering from lung cancer or not. The reason is that you don't know that particular amount of cell-free DNA is coming from benign cells or malignant cells. You can only tell that whatever amount of cell-free DNA that you gave me was carrying an EGFR mutation or a ALK rearrangement or an ROS rearrangement or something else. So liquid biopsy is good for detecting genetic alterations. It is also very good in cases where you do not have sufficient amount of sample in a patient who is a proven case of lung cancer. But no, it cannot be used for today's date, till today's date. Probably after 1 year, 2 years, they might be using liquid biopsy for diagnosis as well. But for right now, we do not use liquid biopsy for diagnosis. Then use of RNA sequencing or DNA sequencing, people are realizing that even though DNA might be mutated, it might be silent. That means it is not getting transcripted to RNA, which is not getting translated to something else, and hence that particular mutation is not very effective in causing lung cancer, or it will not be very beneficial if you target that. So to truly pick up patients who might benefit from targeted therapy, it is better to sequence RNA. But RNA is a very sensitive entity because you cannot preserve it and you need very specific solutions for its extraction. So this is advancement which is happening. Finally, a lot of thing is happening in immunotherapy. I think Dr. Sudeep sir will be talking about that as well. What I want you to understand is that even though immunotherapy is an oncologist field, you have to be aware about the side effects of immunotherapy, which are going to bring the patient back to you. And one of the most horrendous or one of the most dangerous side effects is the pneumonitis. And believe me, around 4 to 8% patients will develop pneumonitis. That can be in the form of development of, and that can be picked up or presented by the patient in the form of cough, fever, dyspnea. And you will have to interpret which part of the lung tumor is which part of the lung lesion is tumor and which part is the GGOs or the inflammatory part, because it will be an important decision on your behalf to make, because after that patient cannot receive immunotherapy again. So you should be aware about the side effects and the presentations of pneumonitis, especially patients who are receiving immune checkpoint inhibitors or other forms of immunotherapy. I think that's all from my side. I will be very happy to answer any of your questions. I think I've done some awareness among you guys to look up to lung cancer with some kind of hopefulness and positive attitude. Thank you so much for your kind attention and time.
Thank you, Pawan. You have done great. And in such a simple, lucid language, and you have covered the whole scenario. It was difficult. Actually, I understood that you could not and should not be limited to lesser time. In that sense, it would not be that conveying to the students. Just one or two comments before we go to Sudeep. You know, before EVAS, we used to have EUS. Before EVAS, because the gastro people used to do it for us. I remember there is a hilar lymph node. We didn't have EVAS that time. We invited the gastro person. You go through the esophagus and try to approach it from your side. And then EVAS came, and again, it has been available now almost most of the medical colleges and centers all over India. Number two is your comment about the pleural effusion, very important. Pleural effusion in a patient of lung cancer does not mean malignant effusion. Either has to be proved or disproved. Anyway, because once you utter pleural effusion, it becomes stage 4. So naturally, pleural effusion is very important. Fortunately, again, Pawan, thoracoscopy is again almost available now in most of the centers, most of the medical colleges. So practically, we are better armed now than what we were even say 10 or 15 years back. Your comment on liquid biopsy is very welcome. People still have some confusion about this liquid biopsy, the purpose, the indications. I think students will, one class cannot make everybody a scholar. So this is basically a sensitization. That you said about this in very simple terms, the purpose and the limitations of liquid biopsy, I think will propel the students to read more about liquid biopsy. And then the most revolutionary part, the therapies, you have enumerated them. Actually, I have seen now recent generation oncologists are more keen to target therapy rather than chemotherapy itself. And of course, immunotherapy is making a mark. So, Sudeep, are you there? So, I think next,
Yes,
hello,
sir, I'm here.
Arvind, are you here? Okay, we are, Sudeep, you are there. Now we need Arvind. Arvind, we are now going to Dr. Sudeep Das. Dr. Sudeep Das, please. The recording, yes.
Yeah. Good evening, everyone. Myself, Dr. Sudeep Das. I am consultant and head of medical and hemato-oncology at Medica Super Specialty Hospital. Today, I will be talking on lung cancer and precision medicine. So, at the outset, I want to thank Professor Dr. A.G. Ghoshal, sir, for inviting me. So, lung cancer and the role of precision medicine is actually a success story of precision medicine. Uh, I'll be talking on how to establish the diagnosis of lung cancer, how important is the molecular type establishment of lung cancer, how staging evaluation, staging workup is done, and what are the patient factors like age, performance score, like ECOG score, and comorbidity, which actually help us to guide the treatment, make the treatment decision for a particular patient. Now, we all know that we need tissue for diagnosis of lung cancer. But unfortunately, very often the patients who come to a medical oncologist, they come with a FNSC report. So we always discourage fine needle aspiration cytology for diagnosis. Uh, the we prefer a tissue biopsy, either a CT guided when the tumor is at the periphery, or a bronchoscopy guided biopsy. Why? Because tissue is an issue for us. Uh, Tissue is required for not only for the diagnosis of the lung cancer, but the molecular typing of the lung cancer. Why that is essential, we'll see in next slides. So this is the age-old histopathological classification of lung cancer that we all know that historically lung cancer were classified in two classes, small cell lung cancer and non-small cell lung cancer, whereas non-small cell lung cancer consists around 80% of lung cancer. And then non-small cell lung cancer, again, they were sub-classified in either undifferentiated or squamous cell carcinoma or adenocarcinoma or some large cell carcinomas. The bronchoalveolar carcinomas, they are considered to be a type of adenocarcinoma. But in the present era of precision oncology, this classification is losing its value day by day, and that is why, if you look at this picture, and this is all the penguins look like same. To a common man, they are all penguins, and they are same and they are similar. Similarly, uh, it seems that all non-small cell lung cancer are pretty similar, but it's not like that. A wildlife, probably a wildlife expert, can differentiate from one type of penguin from another type of penguin, and he can similar way to a medical oncologist. There are different more than 20 types of non-small cell lung cancer, particularly adenocarcinoma of lung. They are molecularly completely different. They behave in a different way. Their biological behavior is slightly different, and that's why there should be a different treatment strategy for treating these adenocarcinomas. So, so this is the evolution of non-small cell lung cancer types. Earlier, when there were only two types, squamous and adenocarcinoma, and now the classification is evolving as molecular classification, where we can see that there are different types of mutations, and these mutations are not only coexistent mutations. There can be hundred or thousands of mutations, coexisting mutations present in the tumor cells. But one need to understand that there are some mutations which we call driver mutations. That means that is the key mechanism to actually for the pathogenesis of the cancer, and that is the Achilles heel. Where if you can target that driver mutation, you can actually arrest the cell growth, and actually you can control that disease. So now we know that there are at least more than 20 types of driver mutations, and there are some targeted therapies are available for those driver mutations. We call them actionable driver mutations, and for some of the driver mutations, the targeted therapies, the oral drugs are actually in pipeline in research. Um, so, what are the common driver mutations? Typically, the KRAS is one of the most common driver mutations, and followed by EGFR. Then we have ALK, we have ROS1, we have MET, we have VRAB mutation, we have RET mutation, we have NTRK mutation, we have PIK3CA mutation, even we have, yes, HER2 mutation as well, apart from what we see in breast cancer. Then we have MEK1 mutation. So there are plethoras of mutations. Actionable driver mutations are present in non-small cell lung cancer. And very important, pertinent two observation to be mentioned, that these actionable driver mutations are, most of these actionable driver mutations are more common in patients who are young, who are some of the actionable driver mutations are more common in non-smoker and in female, particularly in EGFR, AL. These are the two most common actionable driver mutations, but they are more common in non-smoker, young patients, female patients. So that's how the molecular classification of non-small cell lung cancer is evolving. So this is on your right, you can see that this is the data published from Tata Memorial Hospital, that what is the landscape of actionable driver mutations in Indian populations, where you can see that EGFR is as common as almost 29%, and followed by the ALK was the second most common driver mutations. So when we are treating a lung cancer, we should know the what is the in depth, that what is the type of that lung cancer we are actually dealing with. Histological subtypes, squamous or non-squamous, that is not enough. We need molecular testing. It can be done from primary tumors, or it can be done from metastatic lesions. They are equally suitable. So if you know the patient comes where the primary is very deep seated and biopsy is technically difficult, then where you have a very accessible large supraclavicular node, or you have not so deep seated liver metastasis, probably even any biopsy from those metastatic site will be judicious. The same way, many a times patient presents with huge, massive pleural effusion, and in such situation, we can take help of pleural fluid cell block. Please note that pleural fluid cell block is more informative because it gives you good DNA content for molecular testing rather than just doing a pleural fluid cytology. Here I want to mention the role of liquid biopsy. We'll see the role, what is liquid biopsy and what is the importance of liquid biopsy in next slides. So the present guideline, NCCN or ESMO guidelines, they say that in all non-squamous adenocarcinoma, they should be tested for different molecular driver mutations, particularly EGFR, ALK, ROS1, MET, BRAF, and a broad molecular testing by next generation sequencing NGS is preferred and should always be encouraged. Now, for squamous histology also, broad testing are also encouraged. And not only that, immunotherapy is the buzzword in today's oncology practice. So to know that how this patient is eligible for immunotherapy, one need to do PDL1 expression on the biopsy tissue by immunohistochemistry testing. I will come later for what is PDL1. So these are the molecular technologies carried out for molecular classification. One can do FISH, one can do take help of IHC. Suppose ALK has a good concordance between IHC and FISH and NGS. So in IHC, in a good lab, gives you more than 80 to 90% confirmatory evidence that this patient is ALK positive lung cancer patient. Or you can do RT-PCR for EGFR, or you can do also NGS, next genome sequencing. What the advantage of NGS is that with a single test of NGS, actually you can assess different multiple genes, 10 to 12 or 20, even more than 80 genes you can assess with NGS. But the drawback of NGS is that it is time consuming. So a patient who is very symptomatic and he needs immediate treatment, probably NGS is not that good enough, and one can rely on IHC for ALK and PCR for EGFR in such scenarios. So this is some points on liquid biopsy. What is liquid biopsy? Lung cancer tumor, whether from the primary or the metastatic sites, they are DNA shedding tumors. So in the patient's blood, there is good volume of actually cell-free circulating DNA. So this technology, there are technology which exploits, you collect blood sample of the patient. From there, you isolate the cell-free circulating tumor DNA from the patient's blood, and from that, actually, you can sometimes you can diagnose the lung cancer. What is the importance of these tests? The advantages are that these are minimally invasive, particularly important when the primary tumor is so deep-seated and the biopsy is technically very challenging, and sometimes even patient is not also because patient is not in good shape. He has a lot of comorbidities and patient is very symptomatic. Patient is in ICU and is not in a stable condition to perform a invasive biopsy. Liquid biopsy is very important in such situation. And not only that, there are other importance also. Suppose a patient who is taking a form of therapy and he is progressing on that first line of therapy. In such situation, you want to know that what molecular level changes happened in that patient's tumor tissue. maybe that repeat biopsy may not be very comfortable for a cancer patient. And in such situations, liquid biopsy is very helpful. And a liquid biopsy also actually represent uh, cell-free DNA from different parts of the tumor. Because when the tumor is progressing on a particular first-line therapy, maybe that all the tumor is actually heterogeneous biologically. The all parts are not progressing. Some part is actually still responding to the first-line therapy. Some part is progressing. So when you do liquid biopsy, you actually have representation of from all the part of the tumor. So these are the importance of liquid biopsy. So, what are the staging workup of lung cancer? We all know that whole body PET CT scan is most informative, and today we are moving from CT scan, thorax, abdomen, pelvis, plus a bone scan to shifting towards a PET CT scan. There are very crucial role of EBUS, endoscopic ultrasound, and video assisted medistinoscopy, particularly a patient who is being considered for surgery. And when we do MRI brain in symptomatic patient and any patient who is being worked up for surgery. So, so these are the stage-wise guidelines for that lung cancer management for stage 1A to stage 3A. Any patient who is medically operable, the patient should be assessed for surgical operability. If the patient is operable, then surgery is the standard of care. And from stage 1A to stage 3A, if the patient is not medically operable, then in the option is next best option is with curative intent is radiotherapy. So for stage 1 and stage 2, in such medically inoperable cases, the patients are treated with stereotactic body radiotherapy, SBRT, and for stage 3A and also stage 3B, that means where the mediastinal nodes are there into disease, they are not operable surgically, they are treated with concurrent chemoradiations. So this is the NCCN guideline. So here is the importance of doing a EBUS, needle aspiration biopsy, because it has very high sensitivity and 100% specificity and very good positive predictive value as well as negative predictive value to evaluate mediastinal lymph node. Please note, presence of mediastinal node makes it into disease, and these are the patients who are actually most of the time inoperable. Only single station into disease can be considered for operable, but in multi-station into disease are usually inoperable and they are treated with concurrent chemoradiations. So this is the a diagram to understand that how you first do a PET CT scan. If a PET is showing that mediastinal node is negative, then apart from some of the clinical scenarios like N1 disease or central tumor or tumor more than 3 centimeter, you can go for surgery. But if the PET CT scan is showing mediastinal lymph node is positive, then you need to prove it histopathologically by doing EBUS or US guided biopsy before you jump on for surgery. However, there are enough evidence that even in a operable lung cancer patient, there is tremendous scope for improvement because from this table you can see that the 5-year survival rate for most of the operable lung cancer patients are not that impressive. Even in stage 1A, the 5-year survival is just 67%. And for stage 2A, it is 55%. So half of the patients are actually eventually failing, and the most common site of relapse is actually distant sites. So that's why the adjuvant chemotherapy came into the role to play, and there are different trials and large meta-analysis like less meta-analysis which prove that adjuvant chemotherapy improves overall survival at 5 year uh, and the magnitude was 5.4%. Now coming to what is the role of precision oncology in operable lung cancer patients. This is one of the landmark ADAURA trial. This trial, actually, the patients who are EGFR mutation positive and operable lung cancer patients, after completion of their adjuvant chemotherapy, they were randomized into either placebo or third generation anti-EGFR tyrosine kinase inhibitor oral drug osimertinib, and see the hazard ratio for disease-free survival was in favor of osimertinib. The hazard ratio was very, very impressive. It was 0.17. And see the beautiful separation of DFS curves at 2 years, at 3 years. So see, at 3 years, patients who are taking adjuvant osimertinib, the disease-free survival rate were at 3 years 80% compared to only 28% patients who were not taking osimertinib. So this is one of the landmark success story of precision medicine in lung cancer management. Now, another very important strategy to treat patients of lung cancer is immunotherapy. So first, immunotherapy was proven its tremendous role in advanced stage lung cancer, and subsequently there was a lot of enthusiasm of using immunotherapy in even in early stage lung cancer, that means operable lung cancer patients. So this is one of the landmark trial, CheckMate 816 study, where operable lung cancer patients, they were randomized into either surgery or they were randomized into chemotherapy plus immunotherapy, that is nivolumab. And what was the result? Chemotherapy plus immunotherapy nivolumab, actually that arm achieved 24% pathological complete response compared to only 2.2% chemotherapy alone arm. And this also translated into event-free survival. At 2 years, there was almost 20% difference in median event-free survival. So that proved the role of immunotherapy, not even in early stage and operable lung cancer patients. So the patients who are not operable and locally advanced, particularly stage 3A or stage 3B, who are being treated with concurrent chemoradiation with a curative intent, it's very surprising that their median progression-free survival is not that great. In the landmark trial, Pacific trial, patients who are treated with concurrent chemoradiations, the median progression-free survival was just 5.6 months. But the patients who were treated with another immunotherapy, durvalumab, after completion of chemoradiation, there the median PFS was 16.8 months. So from then, it has become a standard that you treat locally advanced lung cancer patient with maintenance durvalumab after concurrent chemoradiation. Now coming to stage 4 lung cancer patients management, where the role of precision medicine is actually more profound. Historically, the median OS with conventional chemotherapy in stage 4 lung cancer patient was just 9 to 11 months. And there is tremendous improvement in outcome of advanced lung cancer patients, and the whole credit goes to precision medicine, because now you molecularly you type the patients, you try to identify that what is the driver mutation for this particular patients, and you can see there are a lot of driver mutations, and these driver mutations are actionable. For many of these actionable driver mutations, targeted therapies, and these targeted therapies, we call it TKI, tyrosine kinase inhibitors. They are mostly oral drugs, and they are available in market. And like EGFR, ALK, ROS, MET, PIK3CA, NTRK, MET, HER2, and on your right, these are the bars where you can see so many approved drugs are available for each and every actionable driver mutation. So suppose for EGFR, you have first generation anti-EGFR drug like gefitinib, erlotinib, and then you have second generation anti-EGFR drug like afatinib and dacometinib, and now you have third generation anti-EGFR drug, osimertinib. Why so many generations? Because not all the EGFR mutations are same. EGFR mutations, they can actually, there are different types of EGFR mutations, and it's seen that these EGFR mutations are actually biologically, they respond to anti-EGFR TKI differently. So there are some type of EGFR mutations which are more sensitive to TKI, first generation TKI. There are some EGFR mutations which are actually not so sensitive to first generation TKI, where we prefer to use a more potent, more effective second or third generation TKI. Not only that, the third generation TKI like osimertinib, the third generation and most latest anti-EGFR TKI, they have very impressive intra-CNS activity, which is not there in the earlier generation TKI. So, osimertinib can actually prevent development of brain metastasis, and it works beautifully in patients who are presenting with brain metastasis. So, this is one of the example, like 60-years old lady without any comorbidities and non-smoker. I told you that these are the patients, female, non-smoker, these are the patients who actually harbor the incidence of actionable driver mutations, particularly EGFR and ALK, are very common to them. She presented to me with hemoptysis. PET scan showed active lesions, and there are multiple skeletal nets. And this patient, these are the baseline PET CT scan showing this is the primary in right lung. There were some hilar nodes, and there were some vertebral mets as well. So the biopsy report came as that well differentiated adenocarcinoma. But I told you this just histopathological diagnosis is not good enough to treat a advanced non-small cell lung cancer. So NGS was asked by us, and NGS proved that this is the EGFR exon 19 mutation. This is the exon 19 deletion, and this is the most common and EGFR mutation, and this is also very sensitive to all the TKIs. So these are the different types of EGFR mutations I was referring to. Exon 19 deletion is the most common, and followed by exon 21 L858R. And to mention here, EGFR insertion 20 is actually one of the type of exon 20 insertion is one of the type of EGFR mutation which are not very sensitive to anti-EGFR mutations. And another important T790M mutation, EGFR mutation, which is the not very common primary mutation, but it is one of the most common secondary mutations causing resistance to first-line anti-EGFR therapy. So this patient was actually treated with the second generation anti-EGFR TKI dacometinib, and the trial, Archer trial, showed that when you use dacometinib, the median overall survival was 34 months. So now, even in a stage 4 lung cancer patient, who has actionable driver mutation, you can expect a median survival more than 3 months, even up to 5 months, more than 3 years to 5 years using these novel drugs, which were previously unheard of. And when you use a third generation osimertinib, this is the data from trial, and this trial showed that osimertinib with median overall survival was 38.6 months. Uh, so this is the real photo, PET-CT photographs of that lady. The upper one was the primary tumor. After just 3 months of dekumetinib, this was a response scan showing beautiful regression of the primary tumor. This is another patient. The patient's histopathological diagnosis was non-small cell lung cancer, and the patient was negative for TTF1, which is the classical IHC marker for adenocarcinoma. But you see, when we asked for molecular classification, and as I was mentioning that ALK is ALK can be successfully actually identified even on IHC, and this patient was actually diagnosed as ALK positive lung cancer on IHC only, and the patient was treated with crizotinib, the first generation ALK inhibitors, and just after 3 months of crizotinib, you see the first response PET-CT scan, complete metabolic and morphological response in the primary, in the hilar node, in the suprarenal gland, and even in the bone met sites. So such is the beautiful response. Typically, with the TKI molecule, the response rate is as high as 80 to 90%. Now coming to few words about, on immunotherapy. So cancer cells, they escape immune surveillance through PDL1 and PD1 interactions. So drugs, those target against these agents, PD1 or PDL1, they are used as immunotherapeutic drugs. Some of the example are like nivolumab, pembrolizumab, or atezolizumab, or durvalumab. So Professor Tasuku Honzo and James P. Allison, they actually discovered the immunotherapy, and they were awarded Nobel Prize in Medicine in 2018 for this Nobel discovery. So to just understand that what is the mechanism of action of immunotherapy, here is the tumor cells. On the tumor cells, you have a protein which is PDL1, and there is the surrounding T cells, T lymphocytes has a protein PD1. When there is an interaction between this PDL1 and PD1, there is a negative stimulation to the T cells, and that's why the T cells get inhibited. If you can block this interaction between this PDL1 and PD1, actually then this negative feedback you can overcome, and then the patient's own tumor T cells get activated, and which can ultimately can kill the tumor cells. So all the most of immunotherapeutic drugs presently are either monoclonal antibody to either against PD1 like nivolumab or pembrolizumab, or these are monoclonal antibodies against PDL1. Those are like atezolizumab, avelumab, or durvalumab. So, what is the benefit of using immunotherapy? So, if you see the curves, you see that with targeted therapy, the action is tumor response is very fast, but that response also wins off very, very fast. For chemotherapy, particularly conventional chemotherapy, the action is fast, but that is not durable. The beauty of immunotherapy is that maybe in the initial phase, the response is not that fast like targeted therapy, but the response is durable. You see the later half of this curve, you will see that those who are responding, they are responding for a long time. So the response with immunotherapy is very durable. So the patients, so obviously the score of PD L1, PD1, these are the one of the predictive markers for that who are the eligible patients for immunotherapy. So uh, to understand better, more the PDL1 score, the higher the chance of that the tumor will respond to immunotherapy. But you know that's not always true. There are a lot of if and but in there. It's still evolving, and there are other biomarkers like tumor mutational burden, TMB, tumor infiltrated lymphocytes, being used to identify the perfect patients for immunotherapy. But till now, most popular markers are most accepted and most widely used markers are the PDL1 score. So, and these are assessed by immunohistochemistry, IHC. So, any non-small cell lung cancer patients who had a PDL score of more than 50%, you can even, there are enough data to support that you can treat these patients with single agent immunotherapy only without using chemotherapy. And PDL score of 1 to 49% chemotherapy plus immunotherapy, this combination gives you the best result, where you can see the combination actually gives you a 20% improvement in overall survival at 1 year. This is another example of my original patients. This patient has a PD-L1 score of 70%. So this patient was treated with chemotherapy and immunotherapy combination, followed by he presently is on immunotherapy maintenance, and you see this was the first response scan, and you see, except at the periphery, the almost entire tumor is now necrosed and not showing any uptake. So, what are the options for lung cancer management? Surgery for stage 1, stage 2, and stage 3A. Chemotherapy plays a very important role. Radiation also plays an important role, particularly in locally advanced stage 3 patients as concurrent chemoradiation, or stereotactic body radiotherapy SBRT in stage 1 and stage 2 patients who are medically inoperable. There are some rules for angiogenesis inhibitors like VEGF inhibitor bevacizumab. There is tremendous improvement of lung cancer outcome, particularly in advanced stage, by the use of targeted therapies which target the actionable driver mutations. There is landmark trials supporting the role of immunotherapy in advanced stage, as well as now we are also witnessing the widening role of broadening role of immunotherapy even in early stage inoperable lung cancer patients. So, to summarize, there's tremendous progress in lung cancer treatment by targeted therapy. Second and third generation drugs for EGFR, ALK, ROS1, MET, they just do wonder. FDA approvals for BRAF, NTRK, RET, and METers. These approved drugs are already in market. There is promise for KRAS mutation as well, which is most common driver mutations in lung cancer. And we have drug like sotorasib, but till now these KRAS inhibitors are still now in use in second line, not in first line. So we are looking forward for to understand that what is the resistance mutations when they are exposed to first line targeted therapies. There is tremendous progress in lung cancer treatment in the field of immunotherapy, and immunotherapy plus chemotherapy is appropriate for most of the patients as first line treatment. But to note here that immunotherapy is usually not used in any patients who has a actionable driver mutation. A patient who has an actionable driver mutation, they are best treated with oral tyrosine kinase inhibitor drugs, not with immunotherapy, whatever is the PD-L1 score. So, except where there is a targeted therapy available. So, with this, I want to thank you all for your patience listening, and I will be happy to take any questions if you have any questions. Thank you. Thank you once again.
So, Sudeep, it was excellent and elegant. And again, as Pawan did, I'm really happy. Very simple, covering all the informations. Now you both are here and we will have to wind up because concentration does not remain at that level for long. Okay? So you have to wind up. Just tell me. So targeted therapy, immunotherapy, and then radiotherapy, it's okay. Pawan first. Where do you put surgery in resectable cases? Now, the present moment. Resectable cases, surgery. Is it first choice? Yes or no?
Yes. Yes, sir. It is a curative intent, and surgery should always be offered if the patient's condition, overall condition, performance status, and the stage of the disease allows. Surgery is the first line and the first choice of therapy.
So, cancer staging and physiological staging. And
Yes, sir.
if that permit, we'll go for surgery. Sudeep, just explain in simple terms. This is the last one. What is the difference between immunotherapy and targeted therapy? This is a 50 level now. Go on. Immunotherapy versus targeted therapy. What do you mean exactly by the terms?
Yes, sir. Targeted therapy, by targeted therapy, you are using actually targeted therapy, some oral drugs, which will actually target the genetic aberrations, genetic defects. So, not there must can be different genetic defects, but they are not causative for cancer. They are coexistent. But some genetic defects are actually causative to start the stem cell. So, those genetic aberrations we call driver mutations. That was the driver for the tumor pathogenesis. So, if there is a drug available to correct that, we call it actionable driver mutations. So, targeted therapy exploit that actually that philosophy, that science. And immunotherapy is the tumor is a foreign body to host, but still how it can escape from surveillance of T lymphocytes. The tumor is also surrounded by T lymphocytes, but somehow they have the ability to suppress T cells. So that is because the interaction between two protein PDL1 and PD1. If we can block this interaction by monoclonal antibodies against these proteins, then the surrounding T lymphocytes they are getting stimulated, and more T lymphocytes are also are attracted there, and they kill patient's own T lymphocytes. They kill the tumor cells. So immunotherapy exploits these signs.
Done. It's really good. You have explained it very simplest language. Just tell me. So most of the targeted therapies are now concentrated on adenosine. Do you have mentioned something about squamous cells here?
Yes, sir. So, sir, most of the recommendation NCCN, they also say that we should also perform NGS even in squamous. Why? Because many a times the tumor tissue, the biopsy tissue is very inadequate. So maybe the histopathological type was adenosquamous, where we are missing the adeno component. That is one of the situation. Another situation, there are reports also available that even in squamous cell carcinoma, there are reports of that EGFR can happen even 2 to 3% cases. So not so common like in adeno where EGFR constitutes around 20 to 25%. But even in squamous, there are series from India also reported that 2 to 3% cases can be EGFR. So it is because of the research purpose also that if we support not all the mutations, actionable driver mutations, drugs were available just 10 years back. Only 10 years back, only anti-EGFR and anti-ALK therapies were available. But every year, some new targeted drugs are coming up. So if we do NGS for even for all squamous cell carcinoma, then we'll understand what is the landscape of molecular aberration even in squamous cell carcinoma, and we are not sure that whether in next 1 or 2 years what targeted therapy will come in coming.
Okay. Now, Pavan, yours is a big tertiary but referral center. What is the usual stage they come to us now? Previously, I said 40 years back, all stage 3 or stage 4. What is now? Is it more awareness, more sensitization, more diagnosis?
Sir, around 80% of my patient will present at a stage of 3B or higher. Around 10% patient will present at a stage of 3A, and rest all patients will present at a resectable early stage. Despite the awareness, the screening protocols are not very clear in India. The awareness towards screening is not there. We right now we are using lung cancer screening, and we have identified around 6 early stage patients in 100 patients of our screened among high risk patients. So the probability of coming at higher stage is still very high in India, unless and until we start doing staging in these patients, screening in these patients.
And also, just for the students, we should mention surgery has also developed a lot, isn't it? Particularly anesthesia, because in our times it was a dreadful thing to go for resectional surgery in a patient of COPD with lung cancer. But now both surgery and anesthesia, they have evolved a lot. I think it is much less morbidity and mortality now compared to previous days. Any comment, Pawan?
Yes, sir. Now, the pneumonectomy is very rarely done for lung cancer. The surgeon tries to remove the segment or the wedge resection, just removing the tumor and surrounding margins, so that even the lobe is spared. So lung sparing surgeries are very common. People are doing video assisted thoracic surgeries, which means that patient can be discharged after 3 to 4 days of hospitalization in a near complete normal physiological state. So surgeries have done a remarkable progress in recent past.
The last one is to Sudeep. Sudeep, you said about adjuvant chemotherapy. Just explain it again for the student. Adjuvant chemotherapy.
Sir, yeah, here in operable patients, the definitive treatment is surgery. Any modality of treatment which we give before the definitive treatment, we call it neoadjuvant. And if we give any other modality of therapy after definitive treatment itself, then we call it adjuvant. So when chemotherapy is given after the definitive therapy, where in this case it is surgery, we call it adjuvant chemotherapy. There are indications like any tumor size more than 4 centimeter. That is the indication.
Tell us the advantage. How much the advantage in prognosis, lifetime survival, adjuvant chemotherapy with
So the
surgery.
adjuvant chemotherapy with 4 cycles of adjuvant chemotherapy after surgery, meta-analysis says that the survival increment at 5 years will be 5.5% around.
So it's a distinct improvement. Yes or no?
Yes, there is improvement, but you know the improvement, the more you follow the patient, actually the absolute benefit in survival increment actually comes down. So even at 5 years, if the patient is alive for 5 years, then we call it that the patient is cured from cancer. So at 5 years, if there is 5% more survival, then it is significant.
Okay, Pawan, any comment on this? Efficacy of adjuvant chemotherapy after resectional surgery?
Sir, it is a very upcoming area. People who are deriving benefit from these patients, but we are still in a phase. We are understanding the data right now. There are some patients who will progress early, and there are some patients who will not progress early. So we are not able to identify those patients who are at high risk right now. So we are giving this therapy to everyone. After some years, after some time, when we have gained experience about this scenario, we will be able to identify and select patients who will benefit from adjuvant therapy after surgery. So only time will tell about this, sir.
Okay. So thank you, everybody. It was actually a great class. I was very happy.
Thank you so much for the opportunity, sir. It was a marvelous experience for us.
Oh, yes. Actually, I enjoy this. I was almost forgetting what time it is. But again, so thank you again. Thanks, Pawan, Sudeep,
Thank you, sir.
our
Thank you, sir.
logistics support partners from Lupin, and audiences, our students, our colleagues who are there all over India and abroad, listening to, tuning to our regular monthly classes. Thank you all. and have a great weekend. Thank you.
Thank you, sir.
Bye.
Thank you. Good night. Sir.
Good night, sir.
Good night.